Rasmussen's encephalitis is a rare and progressive chronic neurological disorder that is described by drug-resistant seizures and atrophy of one cerebral hemisphere. There are two presentations of Rasmussen's encephalitis, with the most common form having an age of onset of around 6 years of age. But although rare, people can also get Rasmussen's at infancy, and even less commonly as an adolescent or adult. However, we will not be focusing on that today as it only makes up 10% of all cases. Histologically, the hallmark features of Rasmussen's encephalitis include: Number 1. Clustering of microglia around necrotic brain regions, or what we like to call microglial nodules. Number 2. Blood vessels surrounded by lymphocytes, or perivascular lymphocytic cuffing. And Number 3. The phagocytosis of neurons, or neuronophagia. A study from the United Kingdom recently estimated the prevalence of Rasmussen's to be 0.18 per 100,000 people. If we apply this figure to the Australian population, this means there are approximately 4 new cases of Rasmussen's per year. However, there is currently no research on how sex, geographical location, and ethnicity impacts susceptibility.
Despite the growing evidence for an immunopathological foundation of Rasmussen's encephalitis, the primary cause of this disease still remains unknown. The most widely accepted pathogenesis of Rasmussen's is the T-cell cytotoxicity pathway. While separate processes like the antibody-mediated response and the microglial activation pathway have been suggested, it is really important to understand that the actual pathophysiology likely involves all of these mechanisms. Recent evidence strongly suggests the importance of cell-mediated immunity in the pathogenesis of Rasmussen's encephalitis, mainly focusing on cytotoxic T cells. This causes apoptosis, which underlines the unilateral atrophy of the brain. This can be outlined in the following pathway. 1. The trigger of Rasmussen's encephalitis and its full pathway is still unknown. 2. This trigger causes the activation and upregulation of inflammatory CD8 T cells, 10% of which are positive for a protease known as granzyme B positive. A number of these T cells are in close contact with MHC class I positive neurons. This further highlights how the cell-mediated pathway is involved. These activated granzyme B positive containing T cells release the granzyme B onto neurons and astrocytes, which causes apoptosis and cell death. It is important to remember that this occurs in one hemisphere of the brain, thus causes the unilateral destruction we spoke about before. In addition to this destruction, the T-cell cytotoxicity pathway is also thought to contribute to the initiation and continuation of those intractable seizures patients suffer from. This is due to the astrocytes. As astrocytes control the reuptake of glutamate, destruction of these cells leads to an excessive buildup of glutamate in the tetrapartite synapses of that hemisphere. This leads to excitotoxicity and consequent seizure induction.
It is evident that the T cells involved in the pathogenesis of Rasmussen's only arise from antigenic T cell precursors, suggesting specificity for antigens located within the brain. A future target for research is to look into what this specific antigen in Rasmussen's encephalitis actually is. As both neurons and astrocytes are attacked by these T cells, it's thought that both these cell types express this antigen. However, to this date, the antigen's identity remains unknown, and it's important to consider that the antigen may be autoimmune in nature or a response to a foreign antigen from viral infected neurons and astrocytes. However, very little research has been put into the specific viral triggers, and again, this is another area for future research into the ultimate understanding of this disease.